Respected moderators, elite professors, and my fellow colleagues, Assalamu alaikum. I'm glad that the SANS 2016 organizers have given me the opportunity to present my paper here. It's about minimally invasive percutaneously placed pedicle screw fixation for traumatic thoracolumbar spine. With the advancement of diagnostic tools, mankind has revived the era of improvising therapeutic skills in order to negotiate the challenge of modern medicine. As similar to other surgeries like laparoscopic cholecystectomies, appendectomies, the concept of minimally invasive surgery has incorporated spine also. Now with pedicle screw instrumentation, it doesn't only allows a rigid construct to the patients with traumatic spine, but its horizon expanding to other spinal pathologies like tumor, deformity, and degenerative changes. It was Roy Kumail in 1963 who first developed the pedicle screws. Then in 1995, Matthews and Long introduced the first percutaneous lumbar pedicle screws. Finally, it was Foley et al. In 2001 who introduced the sanction system, which we are still using it today for our percutaneous pedicle screw fixation. Now, it's been traditional that the open surgical technique in literature, it's overwhelming and it's unremarkable, the advantages, but the demand of minimally invasive spine surgeries is expanding throughout the world. So what exactly we are expecting from this MIS? It should provide the same results as the open surgery, but with less of a morbidity. Now it has certain advantages like small surgical cavity, so small surgical scar, less operative blood loss, shorter length of surgery, less of a post-operative pain, early recovery because of early mobilization. Now, it's not just the patient satisfaction that matters, but this procedure is user-friendly for the spine surgeons as well, because it gives an escape from the unavoidable circumstances that the surgeon has to tackle in the OR, like lengthy OR time, continuous noise of suction, and timely requesting the anesthesis for the muscle relaxants in the initial phases of the muscle dissection. But it has certain limitations like inability to achieve a direct canal decompression and inability to do a perfusion technique. We conducted a study from August 2014 till January 2016, and we recruited the patient from clinics and emergency department. Our patients were 17 years of age and above, and they had the AO-type fractures A and B without any neurological compromise. CT was the primary investigation in our study, with few of the patients having polytrauma had only CT scan done. So we recruited 23 patients. Out of these, 19 had road traffic accidents. Among these 19, 11 were having solely thoracolumbar fractures, but 8 had other multi-system injuries as well. We had 4 patients with fall, and this included one of the female patients we had in our study. The majority of our patients were in the second and third decade of life. Patients above 50 were equal for falls and road traffic accident. So we had operated on these patients. 12 of our patients were operated within the 72 hours of the injury. And this included the 3 polytrauma patients we had out of 8 in our study. Now this is important because the patients undergoing MIS had the OR time of between 60 minutes to 80 minutes. And the peroperative blood loss was 5 ml to 15 ml. And this was comparable to the international literature published. The one I quoted is Wild et al. He published a study in 2007. It was a retrospective comparative study, and he concluded that 10 of his patients undergoing MIS technique had less of a blood loss and less operative time. For me, this slide is very interesting because 19 of our patients who had this MIS technique had early mobilization. And this included 6 of the polytrauma patients we had in our study. One of our patients had a 2-level construct, and one patient had a superficial surgical site infection, which required wound debridement, and it settled. Now, these patients were followed for about 6 to 12 weeks after surgery, and none of them had any hardware failure or malposition of screws. But our study had certain limitations, like it was a unicentric study, and it didn't have a large sample size. And we didn't radiologically assist the preoperative kyphotic angle and postoperative Cobb angle correction after surgery. So to conclude, the indications of percutaneously placed pedicle screws is expanding, and it's a ever-expanding literature. Therefore, it's recommended that the spinal surgeon should acquire a experience with the open techniques first before embarking on these minimally invasive techniques. And since this technique is relatively new and not much of a randomized study is present, so large multicentric randomized studies need to be published in order to authenticate its long-term effectiveness. And hence, these experienced spinal surgeons should come up with their knowledge and their expertise to train other surgeons and spinal surgeons and their juniors who are in their early learning curves to improve their surgical skills for such an increase, such a surgery, in order to improve patient satisfaction and to reduce the untoward potential complications. Thank you for your attention.
We'll keep all the questions at the end. Please welcome